Welcome dear students. While studying about specific forms of hearing loss, the next under this category is autoimmune hearing loss or immune-mediated inner ear disease. Let us study about this. Autoimmune or immune-mediated hearing loss. This has been defined as a bilateral sensorineural hearing loss more than or equal to 30 decibels at any frequency plus evidence of progression in at least 1 year. In at least 1 year. How do we identify this progress? By doing 2 serial audiograms on 2 serial audiograms. In any serial test, a time interval has to be mentioned. So, progression in at least 1 year on 2 serial audiograms that are done at equal to or less than 3 months apart. And what should we observe in these audiograms? The progression should be at least, how do we define the progression? It should be at least more than 15 decibels at one frequency. At the same frequency, we have to observe a shift more than 15 decibels or a shift of 10 decibels at 2 frequencies, 2 or more consecutive frequencies. At 2 or more consecutive frequencies. Or a significant change in speech discrimination. Let us understand this complex definition again. Basically, autoimmune hearing loss is a progressive condition. Yes? So, what we have to observe is to define the hearing loss to be autoimmune hearing loss. There should be bilateral sensorineural hearing loss of more than or equal to 30 decibels. That is the first criteria. At any frequency, the loss should be more than or equal to 30 decibels. Plus, there should be evidence of progression. How can you make that evidence? By performing audiograms, serial audiograms that are equal to or less than 3 months interval, 3 months apart. They should be less than 3 months apart. And in that we have to observe evidence of progression in at least 1 year. And how do we say there is progression in hearing loss? Either there is a shift of more than 15 decibels in one frequency, or there is a shift of more than 10 decibels in 2 or more consequent frequencies, or there is significant change in speech discrimination. If any of these 3 factors occur, we say it has progressed. And such progression should be observed in at least 1 year by making 2 serial audiograms. Not just 2 serial audiograms that are equal to or less than 3 months apart. By this, we can confirm the diagnosis of autoimmune inner ear disease. So, what are the features of autoimmune inner ear disease? Autoimmune disease causes Immune-mediated disease causes progressive, bilateral and symmetrical hearing loss. It affects both the ears, bilateral, it is progressive in nature and it is symmetrical. Both ears, same amount of hearing loss. If you plot an audiogram, the graph is symmetrical. And it occurs in the age group of 40 to 50 years. Equally in males and females. 50% of these patients also experience vestibular symptoms. Vestibular symptoms such as disequilibrium or vertigo, features like that, motion intolerance. And in 15% of the patients, there is evidence of other autoimmune diseases. 15% of patients have other autoimmune diseases. What are the other autoimmune diseases? Some examples of autoimmune diseases are multiple sclerosis, ulcerative colitis, rheumatoid arthritis, Hashimoto's thyroiditis. There is some evidence of another autoimmune disease along with the autoimmune inner ear disease in about 15% of the patients. Then, how do we investigate this case? First, to establish the above criteria, that is progressive hearing loss, the definition that we have seen, more than 30 decibels at any frequency and progression with serial audiograms, what is the investigation that we have to do? We have to do an audiogram. It is only by an audiogram that we can establish the criteria, isn't it? So, repeated audiograms have to be taken at 1 month intervals. Serial audiograms at 1 month interval. Then this audiogram will show progression. Next, a speech audiogram should be taken. Speech audiogram. Speech discrimination is affected in these patients. Even if the threshold of pure tone audiometry remains same, sometimes speech discrimination is affected. That is why in one of the criteria for progression, along with 15 decibels at one frequency or 10 decibels at multiple frequencies, there was a third criteria given, that is significant change in speech discrimination, and that can be identified by performing a speech audiogram. Next, we do evoked response audiometry. Evoked response audiometry. Why is this performed? To rule out acoustic neuroma. To rule out acoustic neuroma as well as multiple sclerosis. By performing an evoked response audiometry, we can rule out acoustic neuroma and multiple sclerosis. Next, we also perform some blood investigations. Why blood investigations? Because it is an autoimmune disease. So, we check for other autoimmune diseases, antibodies such as anti-nuclear antibodies, anti-rheumatoid factor. We also check for ESR and CRP to know the inflammatory status of the patient. Complement levels can be checked. Blood levels, white blood cell levels can be checked, even the differential counts, that will give us a clue. All these are done. Circulating immune complexes are looked for. Then we have a specific test called as Western blot assay for anti-heat shock protein 70 antibodies. anti-heat shock protein 70 antibodies. An antigen is used that can detect these anti-heat shock protein 70 antibodies. It is not a specific test, but this correlates very much with the active stage of the disease and also response to therapy. So, for that purpose, we perform this Western blot assay to identify those antibodies. After investigations, next comes treatment. How do we treat the disease? Treatment of any autoimmune condition is steroids. It is steroids. What do? We give prednisolone in a dose of 1 mg per kg per day, up to a maximum of 60 mg per day. If the patient is 60 kilos, it will automatically become 60 mg per day. Even if the patient is more than 60 kilos also, we stop at 60 mg per day. More than that, steroid is not given for a period of 4 weeks. Some of them responders, and some of them do not respond. If they do not respond to treatment, it has to be gradually tapered off and stopped. If the patient responds, then we wait till a plateau is reached and then a maintenance dose is decided. There are two types of patients: responders and non-responders to steroid therapy. In responders, after the plateau is reached, the patient is kept on maintenance dose. And what is maintenance dose? 10 to 20 mg alternate day. It is 10 to 20 mg alternate days, on alternate days. Like that we can give for 6 months. If the patient is not responding, if he is a non-responder, then gradually taper the drug. But the long-term adverse effects of steroids have to be kept in mind. In case the patient cannot take steroid for a long time or who cannot take steroid at all, what we can try is methotrexate. Methotrexate is another drug that can be tried at a dose of 15 mg per week for 6 to 8 weeks. If the patient responds, we can continue it for 6 months. If there is no response, then after the 6 to 8 weeks trial, the drug can be discontinued. Because methotrexate is a cytotoxic drug, all the adverse effects have to be borne in mind. Alternative to methotrexate is cyclophosphamide. But cyclophosphamide is even more toxic than methotrexate also. Other alternative treatments are intratympanic steroid injection. If the patient cannot take systemic steroids, intratympanic steroid injection can be tried. Next, plasmapheresis can be tried. Otherwise, systemic IgG can be given. IgG antibodies. These are the various treatments that are given for autoimmune or immune-mediated hearing loss. Let me quickly revise autoimmune hearing loss. It is a progressive condition that is bilateral and symmetrical. It occurs in the age group of 40 to 50 years And in about half of the patients, they experience vestibular symptoms also. And in 15% of the patients, there is evidence of another autoimmune disorder. And the criteria to establish autoimmune hearing losses, there should be at least a hearing loss of 30 decibels, more than or equal to 30 decibels, bilateral sensorineural hearing loss, plus evidence of progression in at least 1 year. Out of 2 years, you should be able to see progression in at least 1 year. On 2 serial audiograms that are equal to or less than 3 months apart. And how do you identify progression? More than 15 decibels at one frequency, or more than 10 decibels at 2 or more consecutive frequencies, or significant speech discrimination loss. This is the criteria. Next, we have to investigate by doing multiple audiograms, speech audiogram, blood tests to look for autoimmunity, and then evoked response audiometry to rule out acoustic neuroma and multiple sclerosis, plus a Western blot assay for anti-heat shock protein 70 antibodies. This will monitor the disease, active disease, and response to treatment. It correlates with the disease severity. Treatment is of course by giving steroids, as it is an autoimmune condition. Prednisolone can be given. If the patient doesn't respond, just taper the drug off. If the patient responds, after a plateau is reached, put him on maintenance dose. Always be mindful about the adverse effects of long-term steroid therapy. If not steroids, methotrexate can be used. If not methotrexate, cyclophosphamide. But cyclophosphamide is more toxic than methotrexate also. Then intratympanic steroid injection can be used, or plasmapheresis can be used. Even systemic IgG injections can be used. This is about autoimmune hearing loss, immune-mediated inner ear disease. Thank you very much.